So yes, how I use echo in my practice. So I will be very practical, but with some physiological concept very well re-emphasized by Michael, my conflict of interest. So first I use echo in ARDS patient because I want to analyze and then to use the heart-lung interaction to improve my patient's management. And I think there is something really key to have in our mind, is that we have around 9% of our volemia distributed inside the pulmonary circulation. And this is clearly this blood volume which matters. And we have, as very well re-emphasized once again by Michael, we have some, in ARDS, some injury of the pulmonary circulation. But in the same time, when I apply positive pressure ventilation, I may decrease the Harvey stroke volume. So with the consequence, I decrease the amount of blood into the pulmonary circulation, I decrease the pulmonary venous return, and so at the end, I may have this kind of pulse pressure variation. And it was very well, and Michael, thank you to remind us the paper published in 2011, I do not remember, you show us the relationship between the tidal volume and the difference between the ejection of the right ventricle and the left ventricle. This is exactly the loss of blood into the pulmonary circulation. And it was reported here in animals. You see during the tidal ventilation that lost around 15% of blood from the pulmonary circulation, and it was very nicely correlated to the amount of tidal volume. Higher they apply a tidal volume, higher was the loss of blood into the pulmonary circulation. And so this is exactly what I do. When I have to manage a patient with ARDS, I combine the critical care echo approach with a more continuous approach with the invasive blood pressure, and I look at how is changing the pulse pressure during tidal ventilation. Of course, sometimes I have patients with shock, but without any pulse pressure variation. So the echo will tell me maybe that there is left ventricular systolic dysfunction, or maybe the patient is still profoundly vasoplegic because of the septic process. But in the case I have significant pulse pressure variation, I know that there is a cyclic loss of blood volume in the pulmonary circulation. And I will use the echo to understand why. And as you can see here, there are two different situations. The first one, of course, which is more related to the preload effect of mechanical ventilation that could unmask the fact that the patient is hypovolemic and could benefit from fluids, but indeed, once again, evaluating the benefit-risk balance in each patient. But on the other side, could be because I have a picture or pattern of right ventricular overload. And in this case, and I will not discuss too much about that, but the treatment is completely different. The fluid expansion is probably useless and even deleterious. I may also combine sometime the central venous pressure. I will say a quick word about that. So in practice, I use TEE and not transthoracic approach for many reasons. So I give you my practice. Just the first reason is that if you look at this paper, TEE looks much more accurate in these ventilated patients. Here you can see that the TEE provided good to excellent imaging quality in most patients and was suitable for interpretation in all patients. It was absolutely not the case for the transthoracic approach for many reasons due to the application of a high PEEP or chest tube or fluid overload on the chest and so on. And so if you look at, for instance, something very key, the sensitivity and the specificity of transthoracic echo to diagnose right ventricular overload compared to the TEE as a gold standard. So the specificity of TTE is very good. So if you visualize an acute cor pulmonale, there is an acute cor pulmonale, but the sensitivity was very bad because of the limitation in terms of image quality. One of the reasons why also is that we have a lot of papers, but I just show you this one, is that TEE only induce very rare side effects. And here it was reported in patients with or without thrombocytopenia, and there were no difference. And the rate of side effects was very, very low, between 0.1 and 0.3%. And it was done in cardiological TEE procedures, so spontaneously breathing patient, something completely different than the patient we have to manage, who are intubated and sedated. So what I want to look at is maybe to have some parameters using the TEE, allowing me to understand if I have the adequate volume inside the chest and in the pulmonary circulation according to the respiratory settings. And the respiratory variation of the supravena cava could be that parameter. For instance, here using TEE from an upper esophagus view, you may observe the longitudinal view of the supravena cava with the airway pressure trace, and you observe in this patient a cyclic collapse of the supravena cava. Probably here that the amount of blood is not adequate according to the respiratory settings. But what I want to achieve in these ARDS patients is that I want to be very specific. So I want to be sure that if I give more fluids, my patient indeed will increase his cardiac output. So I want to have this kind of cyclic collapse once again, because in this situation, I am very specific with a very low sensitivity, but probably I don't care too much about the sensitivity in this situation. Here, at the opposite, there is absolutely no change, so I know that I don't care about giving more fluids because the patient will not benefit for having more fluids. And here I have an in-between situation. So it's not a very beautiful one, but I have some minor change during the TADI ventilation of the supravena cava. So I am very sensitive, but my specificity is very low. So I am a little bit embarrassed to consider giving more fluids in this situation because the risk that the patient will not benefit is very high. I can also use the TEE just to check or to monitor what happens when I change my respiratory settings. And Michael spoke about the effect of PEEP, especially on the systemic venous return. Look at here a patient with ARDS, initially in ZIP. The pulse pressure variation was 9%. You can see only a slight decrease in the RV stroke volume during each TADI ventilation and some variation of the supravena cava. The cardiac index was 3.7. So we decided in this patient to apply a PEEP of 5. Look at now the pulse pressure variation, 11, but especially look at now the huge drop of the RV stroke volume at each TADI ventilation with the cyclic collapse of the supravena cava. And the cardiac index dropped from 3.7 to 2.5. So here I have two options that you have to discuss at the bedside. The first one is maybe to consider removing the PEEP, or the second one is to maintain the PEEP but to give more fluids. And this is what we did in this patient. And we improve a lot the blood pressure, no more pulse pressure variation, no more huge drop in the RV stroke volume, and no more collapse of the supravena cava, with a very significant increase in the cardiac index. Probably that in the future, I will better prefer not a binary approach for managing fluid, especially in this type of patients, but more a continuous one to predict how much will increase the stroke volume when I will give fluids. And this is something that we published very recently with Anderson Eman and Philippe Vignon, just to show you that could be a better approach, and this is something we suggest in this paper. If you look at the parameters which were independent variables of change in stroke volume, it was the pressure gradient for venous return. In this, we had the CVP, and we calculated the mean systemic filling pressure using the Parking formula. This was the respiratory variation of the supravena cava and the respiratory variation of the maximal velocity of the aortic blood flow. And what was especially interesting in this study is that the model works very well if we excluded patients without any RV injury. But when we included patients with RV injury and so potentially ventilated for ARDS, the model works much less. and it allows me to do the transition to the second part of my lecture. Indeed, look at this patient. This patient has pulse pressure variation, very low cardiac index. Look at after blood volume expansion, so he was ventilated for ARDS, absolutely no change in the cardiac arrest, no change in the cardiac index, sorry, no change in the blood pressure, no change in the pulse pressure variation. But look at how was the echo before fluid expansion. This is TEE, this is a mid-esophagus view. Look at how the RV was dilated, completely compressing the LV. So, okay, the LV was underfilled and the LV was preload responsive, but the right ventricle was absolutely not preload responsive, and the pressure inside the right heart was very elevated. This study is really nice and was a little bit surprising for me. First, because this is TEE coming from North America, so sorry, Stephen, but it's unusual, I will say. It was performed by fellows in New York City. You can see that the probe insertion was successful in all studies, so it's not so complicated to put a TEE probe into a patient if the patient is sedated and ventilated. But I was surprised because what they found is that in many patients, 27% of patients, they found a pattern of acute cardiopulmonale or right ventricular overload, which was quite a high number of patients. And especially look at the treatment change managed by the TEE study. In many patients, in most patients, 30 patients, they adjusted the ventilatory settings just because of the TEE evaluation. Of course, in one patient, they considered to give more fluids, but it was not the majority of patients. If you have the TEE probe, and this is the case in your unit, probably, and this is what we do, you need to do at least once a day a TEE evaluation just to look at how is working the right ventricle. If you can't, maybe you can look at this study and to have in your mind the different risk factors for developing right ventricular overload, pneumonia, driving pressure elevated, PNF ratio below 150, PCO2 elevated. And so look at if you have only one risk factors or no risk factors, it is very unlikely that if you do the echo, you will observe right ventricular overload. But if you have 2, 3, or even 4 risk factors, it is very likely that if you do the echo, you will observe right ventricular overload with very immediate impact on the therapeutic management. Look at, for instance, this case. In this study, what we wanted to do is to increase the PEEP, but applying the same plateau pressure. It means that between the baseline and the interventional time, we decreased the tidal volume. And so as a consequence, we observed a significant increase in the PCO2. But in the same time, because we decreased the driving pressure, we decreased the tidal volume, the driving pressure decreased. But look at, despite this decrease in the driving pressure, we observed a huge increase in the right ventricular size, probably mediated by the significant hypercapnia we just induced by our respiratory settings. Look at here, short axis view of the left ventricle. The LV was hyperkinetic because this ARDS patient has septic shock also. No paradoxical septal motion, no RV dilatation. PEEP 7 and now PEEP 14, look at the big difference between both. You have now RV dilatation and paradoxical septal motion. So this is exactly this way you may use the tool to adapt the respiratory strategy. One quick information about prone positioning, because as you know, hemodynamic failure is not per se a contraindication of prone positioning in ARDS patient. Of course, you need to have stabilized your patient, but if you look at the PROSEVA study, many patients were under norepinephrine infusion when proning. And when you turn prone the patient, you improve so much the respiratory mechanics, the homogeneity of lung ventilation, that you will improve the pulmonary circulation and the right ventricular function. And this is something that you may observe using also the echo. Look at this patient before proning, huge drop in the RV stroke volume at each TADI ventilation. RV dilatation, maybe not bigger than the LV, but at least almost the same size of the LV. And paradoxical septal motion. So a typical pattern of right ventricular overload and acute cardiopulmonale. Look at after the proning session, no more drop in the RV stroke volume, no more RV dilatation, and no more paradoxical septal motion. So you really have also an hemodynamic effect that you may observe using the TEE when you turn prone the patient admitted for acute respiratory distress syndrome. And so to conclude and to keep my time, so what is my practice? So I combine echo with continuous monitoring of invasive blood pressure, plus minus CVP that could be really interesting to look at, but it's not so clear at that time, at least for me, how to use it and how to combine CVP with the echo evaluation. As I told you, I prefer TEE, and I do it once a day during the first 3 days following the ARDS than the transthoracic echo. I really want to be especially specific for fluid management using the Harvey size and the SVC collapsibility index. I know that when the Harvey is significantly dilated, probably fluid expansion does not matter too much, but I know that at the opposite, when I have collapse of the superior vena cava, probably fluid expansion matters a lot. And I monitor change of respiratory strategy on RV function, and sometimes the opposite, I even adapt it to the right ventricular function. Could be tidal volume, plateau pressure, PEEP, and of course the effect of prone positioning, as I told you. I thank you for your attention.
Thank you. Thank you so much, Antoine, for this excellent talk. Is there any question? There are 2 questions from the chat, but I think you already responded, but probably to give some key messages, final key messages. The first one was, can and should we assess the risk of giving fluids using echo like lung POCUS? And if so, is there any way to combine and to measure its impact? The second one is, since optimal PEEP is associated with optimal RV function, should we optimize the ventilation now with echo and cardiac output instead of blood gases, which misses the hemodynamic aspects?
So thank you, Alpha. There are 2 good and great questions. So the first one, definitively yes. And we had a lot of data suggesting that when you have B lines, and especially coalescent B lines, the risk of giving more fluids is huge. And so you may combine the critical care echocardiography just maybe to avoid, to rule out some right ventricular overload, because in this case you do not consider any more fluid expansion. And the lung ultrasonography, it was the question, I think, just to have an idea of the risk if you decide, based on the critical care echocardiography, to give more fluids. For your second question, I will say definitively yes, but you have many confounding factors. Indeed, you could consider, and this is true from a physiological point of view, I said by Michael, that the RV function is the result of the balance between the recruitment induced by the PEEP or the overinflation induced by the PEEP. So you could consider that you may use this tool and this approach to titrate your optimal PEEP. The main problem is that you have also many other confounding factors. You have inflammation, you have sedation, you have infection that may also impair the right ventricular systolic function. So it's not so clear, but definitively what you can do, if you decide to increase the PEEP or to apply a high PEEP, please check the TEE or the transthoracic echo to check for the tolerance when you increase the PEEP, just to be sure that you did not induce a right ventricular overload, which will be very deleterious for the patient.